Good morning, everyone. I appreciate you all being here. I'm looking forward to share my progress over the past 6 months. Title of my PhD project is Evidence-Based Solutions for Orthodontic Acceleration. My name is Nazanin Ghods. I'm a dentist and first-year PhD student originally from Iran. First, let me introduce my supervisors, Gabor Varga and Tibor Zelesh. I would like to transform orthodontics with effective non-surgical solutions by delivering evidence-based solutions for orthodontic acceleration. I have 2 ongoing projects. First one started on September 2024 and the second one on November 2024. Title of my first project is Investigating the Safety and Efficacy of Non-Invasive Accelerated Orthodontic Techniques in Adult and Adolescent Orthodontic Patients. More than 5.75 million patients need orthodontic treatment annually in US and Canada. This treatment lasts 18 to 36 months with pain and complications. As a result, 1 out of 4 patients decide to discontinue their treatment. This leads us to accelerated orthodontic methods, which they can be light-based therapies such as LED and laser therapy. They can be electromagnetic field therapies such as pulsed and static. They can be electrical stimulation therapies, or they can be mechanical therapies, such as vibration therapy, ultrasound, and shockwave. These techniques work in a way that when mechanical stimulation increases, there's going to be increase in blood flow, and as a result, healing is going to be stimulated. That's why our aim here is to identify patient-friendly, effective, non-invasive, adjuvant treatments that minimize treatment time and risk. We came up with this clinical question that does accelerating methods combined with fixed conventional orthodontic treatment shorten treatment time and reduce post-activation pain. And we're hypothesizing that these methods used alongside with fixed conventional orthodontic treatment does lead to faster tooth movement and decreased post-activation pain. For this project, we're using PICO framework with population of adult and adolescent patients undergoing orthodontic treatment. Our interventions are accelerating methods we discussed earlier, and our comparator is fixed conventional orthodontic treatment. We have 2 sets of outcomes. Primary is as rate of tooth movement, and secondary, as you can see above, with clinical implications of guideline update and increased patient satisfaction. Our search key consists of 3 domains. Second domain is set up to fit the network meta-analysis approach, and in the third domain, we're making sure we're covering only trial articles. We conducted our search in 3 databases, PubMed, Embase, and Cochrane Library. First, we started with 3,518 articles, and after our selection process, we had 142 articles. 90 articles were eligible for data extraction, and 52 articles were used in systematic review part. We also did the citation chasing process, which we found 60 new articles meeting our inclusion criteria. Here you can see 2 graphs. First graph is distribution of studies by technique. As you can see, laser therapy has been by far the most studied intervention, by 67%. This shows the potential effectiveness and popularity of this method, but also shows a huge gap regarding other techniques such as shockwave, electrical therapy, ultrasound, and magnetic field. Our second graph is distribution of studies by outcome. 72 articles studied tooth movement, but 91 articles studied pain. This shows that even though our primary outcome is rate of tooth movement, yet pain and patient satisfaction also plays a crucial role in evaluating these methods. At this stage, we're done with data extraction process, and we're planning to hand in the information to our statistician team as soon as possible this week. Title of my second project is Investigating the Accuracy of Semi- and Fully Automated Cephalometric Analysis in orthodontic patients. More than 5.75 million patients in US and Canada annually need orthodontic treatment and cephalometric analysis. Cephalogram is a radiograph of sagittal plane of head, which consists of several landmarks. These landmarks are joined together to form plane and angle, and it helps us with analysis of dental and skeletal relationship. It can be done in 3 possible ways: manually, semi-automated, or fully automated. Now imagine you're an orthodontist with 200 new patients per year. You have two possible ways to do your analysis. Either you can do it manually or fully AI. If you do it fully AI, this analysis takes 30 seconds. But if you do it manually, it takes 30 minutes. As a result, you will save 100 hours in 1 year and 30% less error rate in the fully automated way. By error, I mean variability, landmark detection, and landmark identification, which these errors will lead to inaccurate diagnosis and increased treatment time. That's why our aim here is to investigate these methods for its accuracy and speed. Clinical question here is, does fully automated cephalometric analysis provide similar or better measurement consistency and workflow metrics compared to semi-automated and manual method? And we're hypothesizing that this fully automated cephalometric analysis does provide better measurement consistency and workflow metrics. For this project also, we're using PICO framework with population of orthodontic patients requiring cephalometric analysis. We have two intervention groups, fully automated and semi-automated cephalometric analysis. And our comparator is our gold standard, which is manual cephalometric analysis. Again, we have two set of outcomes here, measurement consistency and workflow metrics. And our clinical implications are increased accuracy and guideline update. I have two set of key articles, but as an example, I can show you one of them, which is manual cephalometric analysis. I color-coded my key articles based on primary outcome and secondary outcome. And the article that I highlighted is an article that compares manual with semi-automated and fully automated. For the summary, my first project is expected to be submitted, hopefully on September 2025, and the second one on November 2026. And at the end, as I conclude, I would like to leave you with a quote from the Persian poet Saadi Shirazi. Have patience, all things are difficult before they become easy. I believe this reflects perfectly with the nature of this work. Challenging in the beginning, but rewarding as we move forward. Thank you for your attention.
Congratulations, Nazanin, for your presentation.
Thank you.
My question is regarding your first project. What are the adverse effects of these accelerated orthodontic treatments?
So they can have short-term adverse effect, and they can have long-term. Some patients, according to the articles that I read, some patients had tooth sensitivity after that, or some of them had discomfort. Pain is one of the outcomes to check if they actually like reduce the pain or cause like pain increasement, and also same as root resorption. But one of the adverse effects for, let's say, laser therapy, it can be localized hyperthermia. And also, since these methods make the tooth movement faster, I mean, we're hypothesizing that may make the tooth movement faster, and there's going to be like faster bone formation, so there might not be enough stability after, so there might be increase in relapse. So, yeah.
Thank you.
Thank you very much. We have another question.
Thank you, Nazanin. It was very, very interesting.
Thank you.
About your first project, how widely used is the more advanced technologies nowadays in everyday practice? Can you find them like when you go to an orthodontic in the street?
So technically, you can find laser therapy in most, like not vibration, definitely not electromagnetic field or electrical or shockwave therapy. You can find laser, but as far as I know, laser therapy is still not yet in the practices for orthodontic treatment, because it's still under investigation if they have any adverse effect, if they're actually useful or not. Because according to the articles that I checked, for vibration therapy, there's this huge company producing a lot of vibration devices, but I mean it's not done yet, but according to articles the results are very much vary. Some of them said that it completely doesn't have any effect, so it's still under the question.
Thank you very much.
Thank you. We have one more question.
First of all, I would like to thank you for your presentation. And my question is that how did you categorize the data extracted from the articles?
So I have 8 different interventions, and each intervention, they have different outcomes. So what we're planning to do is that to categorize data based on follow-up time, short-term, medium-term, and long-term, because we're extracting data based on the follow-up time. And also for some of the interventions, for example, let's say laser therapy, there has been 2 different wavelengths of laser has been used. So we're definitely going to categorize data based on the wavelength. And for some outcomes, let's say pain, some of the articles just investigate pain in general. Some of them investigate them in spontaneous pain and occlusion pain. So we're going to also categorize them based on which type of pain, let's say, for example.
Okay, thank you. And also, you just mentioned that there were different wavelengths used in different articles regarding laser therapy. I would like to know how did that affect the end results?
So we have wavelengths such as 850 to 900 nanometer, which this wavelength is mostly used for penetrating in deeper in the tissue. So they mainly work on osteoclast and osteoblast. So they're mostly used in tooth movement procedure, but also there are lower wavelengths such as 650, so they don't penetrate as deep, so they affect periodontal ligament mainly. So they're mainly used for pain, but there's still some articles that, let's say, talk about this wavelength in rate of tooth movement. So we're going to categorize them based on wavelength.
All right, thank you very much.
Thank you very much. One more question, I think.
Congratulations, Nazanin,
you.
for your excellent presentation. My question is for your first topic. I'm very wondering, according to your literature, which technique is the most effective?
So the problem is that for some of the techniques, like shock wave, we only had 1 article. But electromagnetic field and electrical therapy, it was very limited. But as far as I checked, vibration therapy, the results are very varied. So most of the articles said it doesn't really have that much effect, but it's only my prejudgment at this point. But I think the laser therapy has been the most the most result has been in the laser therapy regarding effectiveness. But then again, it differs because they use different wavelength and they use it, some of the articles single use or some of the articles several use. So that also depends as well.